So hi, good morning. Can you hear me by any chance? इसको बड़ा कर सकते हैं स्क्रीन को बड़ा करना पड़ेगा इसको चलिएगा नहीं होता बड़ा नहीं होगा ये इसमें एनिमेशन आनी है प्रेजेंटेशन नहीं है अरे यार कुछ नहीं करा दिखा नहीं ऐसे है ही नहीं दिखा ही नहीं पाऊंगा So, I don't know if you can hear me. I have no clue whether you can or not. ये बात करेंगे हमसे बात करेंगे. Anyway, so we are going to start on malignant bone tumors today. I'll give you a very brief outline of the 3 malignant bone tumors that we encounter normally. I'll just tell you how to diagnose them, what are the clinical features, and how do you go ahead with making a treatment plan for them. So I'm not going to go into those nitty-gritty details of every tumor that the tumor, the age of incidence and blah blah. So that's not really important. What you need to know is, because these are very rare tumors, what you need to know is that there should be a point of diagnosis, because you only encounter these tumors very rarely in your career unless you become an orthopedic surgeon. And in that case, what is important is that you should one case you shouldn't miss, because it's a very important tumor, meaning between limb salvage and amputation. So there's a difference between life and death. So when do you call a tumor malignant? Now, the most important thing in a tumor is, on a picture on the left hand side is a very ferocious dog, one of the most ferocious dogs we know on the planet, and it's called a Rottweiler. On the right side you have a very cute little dog called the Pomeranian, which normally we see. Now, Rottweilers are known to kill human beings, and every year about between 10 to 50 human beings are killed by Rottweilers. So what is the difference between these two? One is very cute, literally a lap dog, and the other one is a very ferocious one. You want to keep away from it. So the difference is that of the look. So the first thing is most important, that whenever you want to say that this particular tumor is malignant, make sure that it looks malignant. It doesn't look benign. I'll tell you how to do that. So similarly over here, the picture on the left hand side is a malignant tumor, an osteosarcoma, while that on the right hand side shows 2 little swellings, if you can appreciate, just underneath the knee on both sides, which is an osteochondroma. So on the left hand side you have a malignant tumor, on the right hand side you have the benign tumor, and the most important finding that you see are that the skin is involved. So a malignant tumor of the bone will involve the skin, it gets puckered, it gets stuck, and there is an impending fungation. So if you see on the left hand side, there is a brownish discoloration of the skin, or rather a blackish discoloration of the skin. This is the place where the tumor wants to come out, peep out, and get fungated, and the whole thing becomes even more messier, as against on the right hand side, which nothing of that sort is present. You may see a few dilated veins, as you can see on the top of that tumor, right on the knee. There's a big dilated vein over there. There are other dilated veins, because these tumors, they express substances which cause neovascularization, so these vein formations happen. And of course, they are very warm to touch. I would say to an extent that they are hot to touch, as against the other one, which is on the right hand side, and that is a tumor which is benign. The skin is normal and normal temperature. And finally, if the malignancy goes unabated, then it can lead to mechanical symptoms. Mechanical symptoms means the joint gets immobilized or stuck, or there may be pressure signs, for example, if it involves the neurovascular bundle. Now, what are the common malignant tumors that we encounter in the musculoskeletal system? We all know that the musculoskeletal system is made up of the bones, the cartilage, and the muscles. Now, the bone includes the bone marrow, which is important, and of course, there is a specific bone marrow tumor, which is plasmacytoma. I'm not going to deal with that, the multiple myeloma. But I'll tell you a thing about the cartilage tumors and the bone tumors, the per se bone tumors. Again, you're not going to deal with soft tissue tumors. Soft tissue tumors are mainly dealt with by the surgical oncologist. So, what I'm going to deal with today is a tumor of the cortical and the medullary bone, and that is the osteosarcoma. I'll tell you a little bit about osteosarcoma. I'll tell you about the tumor which is there in the bone marrow, and that is Ewing sarcoma. Of course, the commonest tumor is the multiple myeloma, as I just said. Now remember, Ewing sarcoma, the origin of Ewing sarcoma is very controversial. Some people say it arises in the marrow, some people say it doesn't arise in the marrow, it arises in the primitive neuroectodermal cells, so there's a bit of a controversy, we'll come to that. And finally, there's a tumor which arises in the cartilage, and that is the chondrosarcoma. So here you see the structure of the bone. It has got a cartilage, it has got a shaft, a marrow, and a compact bone. So tumor rising, but particularly only from the bone, is basically osteosarcoma. Tumor rising from the marrow is Ewing sarcoma, and tumor rising from the cartilage is chondrosarcoma. So that brings us first to osteosarcoma. Now, this gentleman, I don't know how many of you know him, Dr. Siddharth Mukherjee, is a medical oncologist. He's not a surgeon, he's a medical oncologist, and he works at the Columbia University Hospital in New York. And he has written a book in 2011 which was called The Emperor of All Maladies about cancer. It's a pretty huge book, about 600 pages or odd, 600 pages. And for which, of course, he got the Pulitzer Prize for non-fiction in 2011. Now, this book deals with a lot of history about the development of chemotherapy, and of course it does mention, not in a big way, but it just has a passing reference to bone tumor, the commonest bone tumor, which is osteosarcoma. Just a note on that, Dr. Mukherjee basically is from Delhi, so he used to live in Rajendra Nagar, I suppose, and he did something at AIIMS, so he's in kind of an anonymous. Now, this gentleman in question very sadly has left us just recently under very specific circumstances we all are aware. Last week, his last movie got released, which is called Dil Bechara, and we all know that in this movie, he was basically an osteosarcoma survivor. That's what the role he played. Now, that just shows that people who have osteosarcoma basically can also survive, and that is one thing that we need to keep in mind, and therefore, the situation is not as gloomy as it appears in most cancers. Now, and finally, just a little reference to this another very important book which I read when I was an MBBS student, and it's called The Final Diagnosis by a gentleman called Arthur Haley. Arthur Haley has this tendency to write books on specific issues, and in this particular book, The Final Diagnosis actually was an osteosarcoma. So this is a book about a pathologist and his story, and there is a dispute on one of the diagnoses he gives, and that is that of an osteosarcoma, and he's proved wrong right in the end. Sorry to spill the beans. So what is the clinical presentation of an osteosarcoma? This is what we need to know. So once, say for example, you're a pediatrician, you shouldn't be missing on a child who comes with suspected osteosarcoma. Now, this 17-year-old boy presented to us with pain and swelling over the lower thigh since the last 4 months. The pain has been persistent, but it was mild to moderate in intensity. It was never a very severe pain that he was, all over, but the pain was nocturnal. That's the important presentation. Most pains which are of musculoskeletal origin are usually nocturnal. Why nocturnal? Because in the night you're really free and you concentrate on your own self, and it is then that most pains are felt badly. Of course, there was no history of injury. Sometimes you may find a history of injury. This is important, but injury per se doesn't have anything to do in the etiology of osteosarcoma. This is important to remember. But in this particular patient, there was no history of injury. The swelling has been gradually increasing. It's not like very rapid increase, but yes, it was increasing over the last few months. There was no history of fever. There was no history of cough or hemoptysis. Now remember, sarcomas, they metastasize to the lung as against carcinomas. So once they go to the lung, they can cause respiratory symptoms, of which cough and hemoptysis are very important. What did we find on examination in this patient? So the general and systemic examination, of course, are very, very important. You need to know how the general condition of the patient is, because most patients who have sarcomas can be very debilitated and poorly, generally speaking. Systemic examination, you do need to examine the respiratory system, and you do need to examine the reticular endothelial system to see if there's any lymphadenopathy. Normally sarcomas don't go in the lymph node, but still you can. Now here you see what is happening is that the skin was very shiny with dilated veins. As I told you in the very first slide, that's a very characteristic feature of a malignancy. Of course, there is a surgical scar mark present, which is the scar mark of the biopsy. You can see there on the picture on the left hand side. And it was difficult to pinch off the skin from the underlying tissue. So what sarcomas do is that they adhere onto the skin. The skin kind of adheres onto the tumor as the malignancy progresses. And on examination, there was a very firm to hard swelling over the lower third of femur. Now, remember, these are the findings of all osteosarcomas, irrespective of where they happen. So they may happen in the upper end of tibia or the lower end of femur, as in this case, or it may happen in the lower end of radius, upper end of humerus. The findings will remain nearly the same. So it's hard to firm swelling over the bone, and very importantly, the swelling was imperceptibly merging in the surrounding tissues, which is a very, again, a sinister sign. It's a nefarious sign of malignancy, that the swelling tends to become less discrete. Discrete swellings are usually benign, less discrete swellings are probably more malignant. and the swelling was very tender to deep palpation. The whole bone was very tender, and the local temperature was raised. So it was not very hot, but it was warm, definitely warm. And finally, the knee joint movements were free, and there was no neurovascular deficit in the limb, and that is important to know because of our surgical planning. This was the X-ray of that chap. So what is the radiology in osteosarcoma? So what you see over here is something very important, that there is a permeative destructive lesion where? In the metaphysis of the bone. So I hope you know what is the metaphysis of the bone. The metaphysis of the bone is basically the area of the bone. It's a part of the diaphysis which abuts onto the epiphysis. So diaphysis is the shaft or the bone that is formed by primary ossification center. Metaphysis is that part of the diaphysis which abuts onto the epiphysis, and the epiphysis is the growing area of the bone. So these tumors occur in the metaphysis, as in this X-ray you see there is a destructive lesion in the metaphysis of the lower end of the femur. There is exuberant new bone formation. You can see there is a lot of new bone formation all around the tumor. That is actually the tumor. We sometimes call that the matrix of the tumor is osteoid. What is matrix? What lies inside. So in this particular tumor, the matrix is the bone. It's an osteoid matrix. It can be cartilaginous matrix, it can be no specific matrix, and of course it can be a bony matrix as well, as in this particular case. And if you see very characteristically, the tumor is also going posteriorly, and posteriorly there is a periosteal reaction. There is a periosteal reaction in the posterior part. In fact, there is a periosteal reaction in the anterior part also. I'll just come to that. And the periosteum is raised in the form of a small little lump as a triangle. I'll come to what that is called. It's called a Codman's triangle, and what it is, I'll just explain that to you. The next thing is the joint line appears to be intact, so the tumor doesn't appear to be infiltrating into the joint, as on radiology. Of course, it's not a very good thing to say on X-ray. It's more of a sign that we should, a clinical thing that we should see, as well as the imaging thing that we should see on an MRI. And finally, as I said, this is the periosteal reaction. The periosteum is raised above the surface of the bone. Now remember, periosteum has got this very particular, very kind of a funny characteristic that whenever it is raised from the surface of the bone, it forms new bone. Now, what can raise the periosteum? Remember 3 T's for all things in orthopedics. One is trauma can raise it, so a fracture can raise it. Other T is tuberculosis or infection can raise it, that is pus can raise it up. And third T is tumor, a tumor can raise it up. When trauma raises it up like that, when it rises up from the surface of the bone, it forms new bone, and that new bone is called a callus, a fracture callus. When infection raises it, then the pus raises it, it forms a new bone that is called involucrum. And when tumor raises it, of course, that is the matrix of the tumor. So that is a new bone, malignant new bone. Now, if you see what is a sunburst appearance and a sun ray appearance, I'll tell you what they are. Now, sunburst appearance is what we used to characteristically draw as a little child when we used to draw that sun between 2 hills. The sun, when it just comes out on the horizon, whether between 2 hills or at the end of a sea horizon, it gives rise to what is called as a sunburst appearance, as against the sun ray appearance, which is this. This is an osteosarcoma of the upper end of tibia. You see the spicules of bone are formed all around it, and it gives ray as if it's giving out rays. That's called a sun ray appearance. Now, the periosteal reaction, as I said, whenever it happens, the periosteum is raised, it forms a little triangle in that portion, and that little triangle, as you see in this particular picture as well, is called as the Codman's triangle. It's an important sign. So it's not specific for osteosarcoma, so the Codman's triangle can be seen in any tumor which is raising the periosteum up, but described by Codman. This is something like this. So this is another tumor, the upper end of tibia, and where it is rising up, it's forming a little triangle called the Codman's triangle. Just remember that. Then what do we do next in that particular patient that we were discussing after doing the X-ray? We go for higher imaging. The higher imaging you can do either local, which is an MRI, or you can do a distant higher imaging to see if the tumor has already metastasized when the patient has come to you. And here you see the MRI. I'm not going to go into the details of the MRI, but the important points that you need to see in the MRI are, you want to see the T1 and T2 images to see, number 1, whether there is any soft tissue involvement. Number 2, you need to see what extent of the bone marrow is involved. So here you can see this particular image that the bone marrow is involved up till here. So you have, this is the free margin of the tumor. All this is involved. And third thing you need to see is what is the neurovascular bundle. So the neurovascular bundle is very close to the femur, and you need to see whether the tumor is involved in the neurovascular bundle or is the neurovascular bundle free. As appears in this particular case, the neurovascular bundle is being encased by the tumor. It's important finding because that will decide what you want to do as a surgical procedure. What about the distant imaging? In distant imaging, you want to see if the tumor has metastasized. The commonest site where sarcomas go, where osteosarcoma goes, is the chest. So you do an X-ray of the chest, but that's not a very sensitive investigation. So you also do an NCCT of the chest, that is a non-contrast or non-contrast enhanced CT of the chest. So you don't require any enhancement, and it will tell you, the slices will tell you whether there are any small little nodules present in the chest. And finally, the peculiarity about bone tumors is that the bone tumors metastasize to bone. It's a very funny thing, isn't it? So if there is an osteosarcoma can go into another bone. And for that, to detect that, we do what is called as a technetium-99 3-phase bone scan. And in this particular patient, you see that there is only the tumor. It's taken on both anterior and posterior sides using a gamma camera. And you see the tumor is only limited in this particular patient to the femur. It hasn't gone out into any other bone, and this is important finding. What blood test do you need in osteosarcoma? Well, by and large, the hematological parameters are normal. The only one thing that may be raised in these patients, particularly in children who are very young, like say 10 years of age, who got osteosarcoma, is alkaline phosphatase. That's important. The children may be anemic, usually, and the hemoglobin may be low, and because of a low hemoglobin, there may be a raised ESR. Now, the ESR is not of the order of 100 or 120 mm in the first hour. That happens in a very specific bone tumor, and that is multiple myeloma. It can happen in Ewing sarcoma also, but usually happens in multiple myeloma. The ESR is 100 plus. So whenever you have a patient who's like 60 years of age and an ESR is of the order of 100 or 110, 120, always suspect multiple myeloma. Now, of course, as I told you that Arthur Haley's book tells us, the final diagnosis is not through any of these means. The final diagnosis is histopathological. So you have to take a biopsy of the lesion. You need to biopsy the tumor to get to a diagnosis. The many types of biopsy are described. The commonest one, for all practical purposes, is co-needle biopsy. Remember, you might be knowing what is an FNAC, the fine needle aspiration cytology, but it yields very poor results in bone sarcoma, so it's nearly given up. The sensitivity is of the order of 90% or 85%, and specificity is around 80%. So it's not done. It's not commonly done in bone tumors. For the bone tumor, the diagnosis is made through a co-needle biopsy. This is how a co-needle biopsy looks like. This is a Jamshedi's needle. It's got a stillet which is pointed, and it's got a shotgun kind of a mechanism at the back where you can punch in a biopsy. Now remember, biopsy is a very important procedure to be done. It's not to be done lightly. The American Cancer Society states that probably no other cancer is as important to perform this procedure properly, because an improperly performed biopsy in a bone tumor will save the affected limb from getting amputation. So remember, if there's a tumor that is suspecting to be a bone tumor, say an osteosarcoma, always go for a core needle biopsy. Now, what does the biopsy show? This is how a conventional type of an osteosarcoma looks like. It shows a malignant osteoid formation, that is a new bone which is cancerous, which is malignant. There are a lot of atypical cells, as you can see in the picture over there. These cells have got plum nuclei, there's the nuclear atypia, and of course there's a lot of new bone formation. There's malignant new bone formation plus another new bone formation, but the malignant osteoid is the hallmark of an osteosarcoma. This is a conventional type of an osteosarcoma, which probably makes us think that there are other types also. Yes, there is other types of osteosarcomas also. For example, you may have the telangiectatic variety, the small cell variety, the low-grade intramedullary variety. These are the intramedullary varieties. You may have surface osteosarcomas, which are relatively benign, which are relatively less aggressive. And of those, the three common ones, the paraosteal, periosteal, and the high-grade one. And finally, you may have secondary osteosarcoma. So, osteosarcoma happens between the age of 10 to 15 years, 15 to 20 years of age. But there is a second peak of osteosarcoma which is associated with Paget's disease, which happens in patients who are 60 plus. And post-irradiation, osteosarcomas also happen in patients who have undergone irradiation, and it can even happen in other bone tumors. So this is how you classify osteosarcoma besides being the conventional ones. The conventional one is the intramedullary primary high-grade osteosarcoma, which can be osteoblastic or fibroblastic or chondroblastic or mixed, depending on what content is there on histopathology. Now, coming to the genetics of it, just a little note on it. Primary osteosarcomas can be associated with certain genetic syndromes. The common ones which are associated are Lee-Fraumeni syndrome, the Rothman-Thompson syndrome, and the one in the middle is very important, which is hereditary retinoblastoma. So if you If you remember your pathology, it was described as the second hit hypothesis. That is the second hit hypothesis in hereditary retinoblastoma which happens. So the child has got a osteosarcoma first, and then he or she develops a retinoblastoma, and he or she then again may have an osteosarcoma. Pretty bad condition to have. Now, what is the treatment of an osteosarcoma? So the treatment is very simple, as I would say to you at your stage. First thing is you give multi-agent neoadjuvant chemotherapy. Neoadjuvant means chemotherapy given before surgery is attempted. The commonly used drugs in different doses, in different regimes, and there are many regimes, you don't need to really go through them. The commonly used are methotrexate, doxorubicin, which is erythromycin, cisplatin, and ectramycin D. Now these are the 4 drugs which are the commonest used drugs, others are also used. And usually we give 3 cycles of these drugs in various doses as neoadjuvant chemotherapy, and then we go for surgery. Surgery can either be salvage, that is, you do a limb salvage or you do an amputation, and then once the surgery is done, the patient is yet again sent back to the chemotherapist or the medical oncologist for post-operative chemotherapy. So another 2 to 3 cycles, depending on how the surgery has gone, how the margins have been, and how the histopathology has been post-surgery, you do a post-operative chemotherapy. And this is what you usually do. We usually salvage them. We don't do an amputation that commonly. 90% patients undergo salvage, 10% have to be amputated. And this is the post-operative X-ray. The same patient that I showed to you, the tumor has been removed, and this all through what is called as a wide resection. That is, you get about 2 to 3 centimeters of normal bone besides the tumor, and it is reconstructed using an endoprosthesis that you see in the clinic. And these people do pretty good actually. This brings us to the next tumor, and that is Ewing sarcoma. Now, it was in 1921 in this New York hospital on the 15th Street. Now this hospital is gone; it's no longer there. That this gentleman called Professor James Stephen Ewing described a tumor. So he described a tumor in 1921. He published a report on a tumor which was later on called as Ewing sarcoma. He was so important that the Time magazine on the January 12, 1931 put him right there on its cover. So getting onto the Time magazine cover is something very important. Doctors very rarely do that. I don't know of any specific individual doctor getting on the Time magazine, except this gentleman. He was called the Cancer Man Ewing. Yes, there have been groups of doctors. Very recently, the Ebola virus group of doctors were there on Time magazine. So it's just a group which is treating Ebola virus across Africa, or even the COVID warriors will come there as a group, no specific. So getting an individual onto the Time magazine as the person of the year is very rare for a doctor. But this gentleman was there in 1931. Now, so what's in a name? Why do we call Ewings Ewings? It's like the patriarchy that we see in this country. You see those pictures of women, who take husband's surname. Someone takes husband's address, and still the patriarchy just doesn't get dismantled. But yes, there is something in the name. So what we now call Ewing sarcoma is what is called the Ewing family of tumors. So this is a group of cancers which includes 4 different tumors. One is the Ewing tumor of bones. We now call it the ETB. Second is the extraosseous Ewing tumors, which are the EOE tumors, which happen in the musculoskeletal system, which happen in the body, but other than in the bone. So they don't happen in the bone. So it can happen, for example, in the liver. Rare, very, very extremely rare. Or the third one of group of tumors are called as the peanut. Now previously the Ewing tumor of bone was also called peanut, no longer. So these are the primitive neuroectodermal tumors. And finally there is a specific group of tumors called the Askin tumors, which are the peanut of the chest wall. So these are the 4 tumors that fall in the Ewing family of tumors, and one of them, the Ewing tumor of bone, is what we are going to discuss just now. How do they present to you clinically? Remember how osteosarcoma presented, that's easy then. So over here the child was like 7 years of age, with pain and swelling in the mid-thigh. Mid-thigh is important. So in the previous patient, it was the lower thigh. It was near the knee joint. In this patient, it was the mid-thigh. And this was happening very acutely kind of thing, or subacutely, like last 2 months only. And the pain and swelling was of waxing, waning nature, which means that the child had a bout of pain and swelling, and then he was all right for another 2, 3, 4 days. And then again, pain and swelling came back, and again in the week, he was all right. And a history of episodes of high-grade fever, very important. So this child had pain, swelling on the thigh, as well as history of pretty high-grade fever. Although again, as in osteosarcoma, there was no history of injury, but there was very, very pronounced generalized symptoms. For example, there was loss of appetite, and there was just disinterest in games, as the parents will tell you, and there was general tiredness, listlessness, as we call it. And he also had, in those 2 months, rapid weight loss, significant weight loss. Now, of course, that brings us to the examination findings. What were the examination findings? As the child was brought to us, he had 100-degree Fahrenheit fever, which is important, and there was a hard to firm swelling in the middle 1/3 of the thigh. So the swelling was not in the lower 1/3 or the upper 1/3, it was right in the shaft. And it mainly arising from the shaft of the femur with the local temperature quite raised. Now remember, osteosarcoma was also warm, but this was really hot. And the skin had dilated veins, deep tenderness was present. These are the features which were there on osteosarcomas also. And the knee joint movements were free, and there was no distal neurovascular deficit. Now, once you have this kind of a clinical picture, remember the history and remember the examination, we begin to think, is this osteomyelitis? Is this infection? And that is the single most important differential diagnosis of AIIMS sarcoma in every patient, and that is very confusing as well, because one of them is a benign condition, osteomyelitis is a benign condition, and AIIMS sarcoma is a life-threatening cancer. So this is very important that you be very clear what you're dealing with. Of course, coming to the radiology, the most important thing was a destructive diaphyseal lesion. As against the metaphyseal lesion of osteosarcoma, in AIIMS you had a diaphyseal destructive lesion. There was again a periosteal reaction, as you see on the picture on your right hand side. This was the Goldman's triangle I was talking about. The periosteum is being raised, but this time periosteum is being raised not by osteo but AIIMS sarcoma. And a very characteristic periosteal reaction happens in these patients. This is not the same patient, it's another patient, just to explain to you. And this is called a lamellar periosteal reaction. See, there are lamellas of periosteum. There are layers of periosteum. And this is similar to an onion peel. So if you open up an onion and you cut an onion and you see what they are, they're lamellas over there. So these are the lamellas of the onion, and these are the lamellas of the periosteal reaction. Why does this happen? It happens because the disease was, remember I told you, it was waxing and waning. So every time the child had fever, pain and swelling, the periosteum raised a little, and then it was quiet, and then few days passed, again the child had the same bout, and again the periosteum rises up and lays new bone. So it forms bone in lamellae. What do we do next? Again, we do the same thing. We do distant and a local imaging. The local imaging, of course, is the bone scan, the MRI. And the MRI over here is important to read, because you want to see whether that it's a tumor or whether it is infection. And a good MRI expert can differentiate that for you. It can differentiate between pus and tumor. And this is important. Again, you do the axial cuts, you do the coronal cuts to see the extent of the tumor. Now, there is some importance of the bone scan. Now, bone scan has recently been replaced. Now, I'm using the word replaced with very judiciously and with a lot of caution, because not every place has got a PET scan. It has been replaced with a PET scan. But since this is a disease of bone marrow, AIIMS sarcoma, the spread can happen within the marrow, and therefore multiple bones can be involved. So it's important to do a bone scan or a PET scan depending on availability. More importantly in this patient than in the patient of osteosarcoma. That is important to remember. So you do a distant imaging in the form of chest CT, chest X-ray, and a bone marrow PET scan. Of course, the blood tests are again very important, because they reveal far more important things than in osteosarcoma. These patients usually have very low hemoglobin. Their ESR is pretty significantly raised, of the order of around 90 and 70. The CRP is also raised. There is usually leukocytosis, and very importantly, the LDH levels are raised. So LDH becomes an important kind of an enzyme which in the blood for these patients. Now, the final diagnosis again is on histopathology. What does the histopathology show you? The histopathology shows a very characteristic tumor. You just can't miss it if you've seen an AIIMS sarcoma once under the microscope. There are sheets of monotonous blue round cells, as you see on the picture on your right hand side. And this is why it's also called as a blue tumor. The nuclei are very prominent for these cells with minimal amount of cytoplasm. You see, this is just nucleus that is seen, and they form what are called as pseudorosettes, just like neuroblastoma. These are circles of cells with necrosis in the center. So, for example, this one over there, we've got a necrosis, and there's a center of cells. A rosette of cells. There's another rosette of cells over here, but they are pseudo-rosettes. They are not the true rosettes. And these cells are very rich in glycogen, and therefore they do. If you do a past staining, they take up the glycogen very well. And on immunohistochemistry, CD99 can be detected in these cells using an immunohistochemistry stain called MYC2. So these cells are these tumors are MYC2, very strongly MYC2 positive. MYC2 is basically it's beyond your preview of curriculum, but MIG2 basically is to detect an antigen called CD99, which is expressed by these cells in immune sarcoma. Again, what is the treatment? Same treatment. It's neoadjuvant chemotherapy, multi-agent. But over here, the drugs that are commonly used are vincristine, doxorubicin, and cyclophosphamide, alternating with ifosfamide and etoposide. So these are the 4 drugs being used over here, but they're used in rather 5 drugs, but they're used in an alternative fashion. So you give a cycle of vincristine, doxorubicin, cyclophosphamide, depending on what you want, and then a cycle of ifosfamide and etoposide. After 6 cycles of neoadjuvant chemotherapy, so as against, remember, 2 or 3 in osteosarcoma, after 6 cycles you go for surgery, again salvage or amputation depending on what you want to do, and then post-operatively again you give chemotherapy, but this time you give 3 to 6 cycles depending on how the tumor has responded to surgery. That brings us to the last tumor of the group, and that is chondrosarcoma. The chondrosarcoma, as the name suggests, chondros means cartilage. This is a tumor which is arising in the cartilage. Now what is the clinical presentation? Usually old age tumor. This was a 65-year-old man who presented to us with pain and swelling in the gluteal region for the last 2 years. The pain was mild to moderate in intensity. The swelling was increasing very slowly. So these tumors have got a very insidious course, not like Ewing sarcoma or sarcoma. There is no history of few months. There is a history of usually years. Whereas in this particular patient, there is a history of 2 years when the swelling appeared and pain appeared. The swelling increased very slowly. There were no general symptoms. He was walking about, doing his daily activities, and there was, of course, as in the last 2 tumors, there was no history of trauma. Coming to the clinical findings in these patients, usually, again, they have a bony heart swelling arising from the flat bone. Usually, it's in this particular case, the iliac bone. So, ilium or the pelvis is the commonest side of these tumors for chondrosarcomas. There was minimal tenderness from deep palpation, so they are not very deeply tender tumors as happens in osteosarcoma or Ewing sarcoma. Usually they are not very painful as well. Of course, local temperature is not raised. This is a deep lying tumor. Whenever the tumor happens in the pelvis, remember it's so deep lying, the symptoms appear late. So these tumors, they come to us with pretty huge sizes as well. And the swelling, of course, in this particular case was huge. As you can see, it's around 20 centimeters by 10 centimeters. So pretty big swelling, and going posteriorly in the gluteal area, coming entirely into the iliac area, and nearly occupying the whole of the pelvis on visibility. Yet the hip joint movements were free, and the femoral vessels could be felt right over there, somewhere over there, onto the over the swelling actually. And so, as I said, the swelling had a global presence. It was there anteriorly, it was there posteriorly, and this happens most of the times in chondrosarcoma because they seek medical help late in the course of the disease. But recently he started having difficulty in passing urine, and that's why he was brought to us. This happens again in pelvic tumors, that because there are important viscera in the pelvis which gets affected later in the disease, they will come to you once that visceral involvement happens. For example, involvement of the urine or involvement of the colon, rectum. Then of course you do the imaging. Now the imaging is very characteristic. You see over there, this is the imaging of that gentleman. You see there are floccules of cartilaginous density, and this is called as popcorn calcification. See this huge amount of calcification that has happened. The remaining bone is pretty much normal, so the lesion is much more well defined as compared to Ewing sarcoma or osteosarcoma. In this particular case, the lesion was well defined to one part of the bone, the remaining bone was normal. You can see the hip joints are pretty normal, and this ilium, even the remaining ilium and the area of the pecten pubis and everything is normal. But this is very characteristic X-ray for chondrosarcoma. It shows up, of course it will show the destruction of the bone, but the matrix is cartilaginous. So remember, matrix in osteosarcoma was osteoid, matrix in chondrosarcoma is made up of cartilage, and this cartilage appears as popcorn calcification, floccules of cartilaginous densities. You may have rings, you may have circles, and of course you may have this particular case. This is the other view that shows the tumor is mainly growing out, and you see there's a bit of a soft tissue component. So they are not without soft tissue component, they do have a soft tissue component as you see in the picture over there, but the remaining part of the bone appears normal. So what I want to tell you, even by seeing the X-ray you can make out that this is an aggressive tumor, but it is not as aggressive as an osteosarcoma or an Ewing sarcoma, and this is important. The other investigation of choice in this patient would be, of course, be an MRI. MRI will show you the local disease, but another investigation in most flat bones is a CT scan, a normal CT scan, non-contrast CT. So remember all those bones which are starting with S, like the sacrum or the sternum or the spine, if you want to see the bony morphology of these flat bones, then or the scapula, the investigation of choice is a CT scan. So CT scan is basically the investigation of choice of most flat bones. When you see the bony window, you want to see the bony window. I'm not saying the MRI is not important. You don't do an MRI in chondrosarcoma. You do an MRI in chondrosarcoma to see the soft tissue involvement, to see the involvement of, for example, in this particular patient, see the involvement of the bladder. But most importantly, you have to do a CT scan to know the dimensions. Of course, the histopathology is very important, and that remains the crux, the final diagnosis. Normally, in these patients of chondrosarcomas, the matrix is very hypercellular with blue balls of cartilage. As you see, these are typical balls of cartilage, and these are the cartilaginous cells all around. They are nothing but enlarged chondrocytes with a very plump, multinucleated lacunae. You see this? This is the chondrocyte. The chondrocyte has become plump, and you can see there's a space in there around the nuclei. And this malignant cartilage tends to be infiltrating into the bone. So if there is a tissue of the bone, of course not there in this slide, then you can see that this malignant cartilage is infiltrating into the bone. Seams of bone are getting destroyed. And depending on what the histopathology is, chondrosarcomas are graded. So you can have a grade 1 chondrosarcoma which is very less malignant as against a grade 4 chondrosarcoma which is dedifferentiated as nearly as malignant as an osteosarcoma or even more malignant than that. So you have the whole spectrum of grading of chondrosarcomas. What is the treatment? These tumors do not respond to chemotherapy or radiotherapy, so this is not a treatment of choice, and the only thing they can respond and the primary treatment is surgical. But they have very high recurrence rates of the order of 25% within the next few years, and these tumors can metastasize to the lung later on even if it does not happen in the primary disease. So over here you see that same patient, the tumor has been removed, and this is the head of the femur now, the eye limb is all removed, these are the vessels on the picture. So, what have we learned today? We have learned to differentiate between osteosarcoma, Ewing sarcoma and chondrosarcoma. As for age, osteosarcoma is a tumor of puberty. It happens in patients who are like 15 to 20 years of age. Ewing sarcoma, on the contrary, usually happens in much younger age groups, usually in the first decade of life, between 5 to 10 years of age. And chondrosarcoma is a tumor of the old age, so is multiple myeloma. Like they happen in patients like 40 and 60 and 70 years of age. The course of symptoms, osteosarcoma is much more acute to subacute, more subacute than acute. In Ewing sarcoma, it is very, very acute course, the heralding course of action which mimics infection, osteomyelitis. As against chondrosarcoma, it's a very chronic tumor, insidious onset, insidious progress. The tumor in osteosarcoma usually happens, the primary lesion happens in the metaphysis. Remember, that's the end of the bone. In Ewing sarcoma, it happens in the diaphysis, while in chondrosarcoma, the common sites affected are the flat bones. The commonest bone to be affected in osteosarcoma is usually the lower end of the femur and the upper end of the tibia. Ewing sarcoma, again, is the lower end of the femur, the shaft of the femur. And chondrosarcoma, it's usually the pelvis or the scapula which are commonly affected. Remember, one of the important signs locally is that the temperature is raised in osteosarcoma. It is significantly raised in Ewing sarcoma and it is not raised in chondrosarcoma because of the heralding course of the disease. The pain is moderate to mild in osteosarcoma. It is very severe in Ewing sarcoma and it is again mild in chondrosarcoma till a late stage. Of course, chondrosarcoma can become very painful, but later in the course of the disease. As for the radiology, the osteosarcoma, you see that there is new bone formation with the Codman's triangle. In Ewing sarcoma, there is destruction with lamellar periosteal reaction. The periosteal reaction in osteosarcoma is usually Codman's triangle, as against popcorn-like flocculent densities in the chondrosarcoma. And all this radiology will happen in osteosarcoma in the metaphysis, in the Ewing sarcoma in the diaphysis or shaft, and in chondrosarcoma in the flat bone. And finally, the treatment for osteo and Ewing is nearly the same. Of course, the duration of chemotherapy varies. It's chemotherapy, neoadjuvant chemotherapy, followed by surgery, and again followed by adjuvant or postoperative chemotherapy. As against chondrosarcoma, the treatment choice is still surgery. Newer drugs are now coming in for chondrosarcoma, but that's again very recent with very limited evidence against it. So that's in a nutshell about malignant tumors. Thank you very much. If you have any questions, please let me know, and we can answer that then. I hope it was clear and I hope it was understandable. So let me know if there are any questions about about this presentation.